So I said we are starting off health and social needs assessments in this session. I'm chairing Mark Bruinsels from the Netherlands. I have a background in population health management. I said we are touring the world, 3 continents, 5 different countries. Will be exciting. We have 5 presentations, max 50 minutes each. So I'm going to be a bit tough on time, or as you have to be as chair. We take questions after each presentation, and we see at the end whether we still have some time left for some other discussions. Then I'm going to introduce the first speaker to this session, and that's Amy Lynch. And Amy Lynch is from Ireland, and she's going to talk about evaluating financial competency and future planning as part of an integrated care comprehensive geriatric assessment. The floor is yours.
Sorry, so my name is Amy Lynch. I'm a specialist geriatric registrar in Galway University Hospital, working with the Galway Integrated Care Programme for Older Person Service. So I'm going to present today looking at evaluating financial competency and future planning as part of an integrated care comprehensive geriatric assessment. So I work at the moment in the Galway Integrated Care Service. So that comprises of 4 ECC-funded ICPOP teams in the west of Ireland. So the populations that are looked after by the service are very varied, from very urban populations to very rural populations. And this is a new and developing service in line with Sláinte Care. So it really strives to give the right care to the right patient in the right place. Who's seen by our service? So the patients that are referred would have a variety of different issues that we try solve for them. So patients with frailty, so that's a new or unexpected change in their mobility or functioning, patients that are having recurrent or unexplained falls, or very commonly a patient with a new or unexpected change in their cognitive function. These patients would tend to be over 75 years. They would have been assessed by the person referring them. They would have a high frailty index on the Rockwood Frailty Score, and would need input by 1 or 2 multidisciplinary team. What we mean by that is would need to be seen by, for example, the medical team and physiotherapist or occupational therapist, and the patient themselves is aware of the referral. These referral criteria aren't strict, and it's really on a needs and case-by-case basis. So the GICOP service will strive to see really whoever needs to be seen. Collaborative leadership is a real theme with GICOP, and there's a lot of in-service days where all of the members of the team will meet and try to think together and see what the aim is. So this was the vision statement decided by all the team members. So it's empowering healthy ageing in your home and community. So again, that's really just tying in with Sláinte Care and looking for right care, right time, right place, and to keep older people well in their homes for as long as possible. Where are the patients seen? So they're seen, initially patients were seen in hospital outpatient clinics, which was quite prohibitive because they would need to travel a long distance, they'd have trouble with parking, and by the time they arrive at the appointment they might be quite distressed. So the move is to see patients in their own community, so either in satellite clinics or more frequently in their own home, which really gives a good insight into how they're living and the problems that they might be facing. So what do we do for the patients? We have a specialised geriatric comprehensive assessment pathway. So I suppose just for people who mightn't be involved in geriatric care, comprehensive geriatric assessment is an evidence-based pro forma to really assess all the facets of an older person's life, to look at how are they functioning at home, what medical conditions they may have, and to really strive to optimise things to keep them well, troubleshoot issues and avoid hospital admissions. So the comprehensive geriatric assessment looks at, as I said, functional capacity. Are they falling? Is their cognition okay? Is their mood okay? Do they have polypharmacy? And then crucially for this project, looking at social supports, financial concerns, and the goals of care. So with this, the comprehensive assessment is carried out A list of issues is highlighted, and along with that a management plan to try troubleshoot any issues. So these range from strict medical issues to social issues to issues with regards to finances. So for this project, just to highlight, the CGA would cover cognition, so any worries about their cognition, and also financial concerns, either now or financial concerns that we might predict become a problem in the future. So the background to this project is we kind of felt that probably the need for support in managing finances independently is an essential component of the CGA, and it's not something that's thought about very frequently, or certainly looking after older patients, maybe it's not at the forefront of your mind, but safeguarding of finances is really important, and something that's important to be thought about early in looking after older people, so that if they have a cognitive or a memory trouble that progresses, that we think about it early, plan for it, so that if things become a problem in the future, we kind of have the supports in place to deal with it then. So we sought to evaluate financial competency and preparedness in an older population attending our integrated care service in East and West Galway. So participants included in our service development project were new participants referred to the integrated care service between January and May with completed comprehensive pro formas. And then we kind of collated the data, and a retrospective analysis was conducted looking at the patient demographics, the ability to independently manage finances. So that was as per, there's kind of a section in the CGA asking them, were they subjectively happy with their finances, and also asking their caregivers, was there any concerns highlighted? And the level of dependency that the patients had for personal and instrumental activities of daily living. So personal ADLs, we call them, would be, can they get dressed themselves, or kind of do they need to help with those type of things? That would be measured by the Barthel index. And then instrumental ADLs was measured by the Lawton-Brady tool. So this is really useful and kind of quantifies a lot of the things that we do day to day that people may need increasing help in as they get older, or if their level of frailty increases. This very helpfully has a separate section looking at finances. So there's different grades of financial dependence in the Lawton-Brady. So the first grade, are they completely independent? Do they manage rent and bills and everything okay? So they really don't need very much input at this stage. So they would score a 1 for that. And then the second grade was that somebody would be able to manage day-to-day purchases, but maybe bigger purchases or more complex purchases might need a little bit of help with that. So they would also score a 1. And then if they have very significant trouble managing finances, they would score a 0. So as I said, just to bear in mind, the score of 1 has different grades to it. So our results. The median age of patients that we were seeing was 81. 56% of patients were female. 44% were married and living with a partner, and 33% were widowed. And I suppose who they're cohabitating with was really very significant with managing finances or any trouble that they might come across. And then very significantly, 33% had a documented mild cognitive impairment. So mild cognitive impairment would be defined as a little bit of memory trouble, or potentially a lower score on the scoring tools, but no functional impairment day to day. So their memory trouble doesn't really impact on their day-to-day activities. And then 53% had a documented diagnosis of dementia. So that's memory trouble that would impact on your day-to-day activities. And just to highlight again, the issues with memory is a real spectrum. And because somebody had a diagnosis of dementia documented, it just really means that we need to kind of practice person-centered care and meet them where they're at, and really make every aim to put things in place so that we can manage their finances with them, or that they will be able to get support to manage finances as far as possible. So looking at the functional and cognitive assessments of the Barthel score, looking at the PADLs, is 17 out of 20 was the average score, which is a reasonable level of dependence. The Lawton-Brady scale is 4, which would indicate that the patients would need a reasonable degree of help with their IADLs. And then the MOCA score, which is the cognitive scoring score, is 17 out of 30, which would keep with the patients having a diagnosis of mild cognitive impairment or dementia. So looking at the results from the financial capacity assessments, so we found that no patient had an advanced care directive. 90% didn't have an enduring power of attorney. So in Ireland, that's a legal setup that you nominate usually a trusted family member as your power of attorney. If you were to lose capacity at any stage, then it can be enacted, they can step in and help you manage your financial affairs and day-to-day affairs. But it does need to be set up with a solicitor, which is often a rate-limiting step. 41% didn't have a will, and then 80% of patients scored 1 in the financial section, which, as I showed before, shows either they're very independent or they're partially independent with their finances. 60% of patients collected their own pensions and felt that they were self-managing their finances. So to conclude, we found that although we highlighted that from our patient cohort there would be a high prevalence of cognitive impairment, so there's a likelihood that patients are going to have trouble managing their finances themselves, we found that very few had supports in place either now or in the future to help them safeguard their finances. We feel and kind of found that future planning for financial matters is a really key area of intervention and discussion for integrated care teams, and will be a really key sticking point to try and empower patients to live kind of how they'd like to live and manage their finances going forward. Limitations with regards to financial planning in older people in an integrated care setting. So there's no medical social worker attached to either of the integrated care teams, which I suppose is a big problem. So that's going to be part of the workforce planning going forward. So the primary care social worker is quite heavily relied on. As I said, enduring power of attorneys are very useful, and they really can help streamline things in the future if the person were to lose capacity. So they're very important, but the legal pursuit of an EPOA can be very financially onerous on families and quite difficult for them to attain. And then I suppose another issue at the moment is that there's been a change in legislation in the south of Ireland. So there's been a legislation called the Assisted Decision Making Act, which has been brought in to try and protect vulnerable patients and really optimise them to try have them be supported in their decision making. But so it's not technically related to EPOA, but the spectrum of EPOA has become a little bit more grey, and I think solicitors, some of them are getting a little bit more hesitant to bring them in. So that's a problem that we're going to have to deal with, and probably will become more prevalent going forward. So just to emphasise again that supported decision making is really essential to uphold the right of older people to make choices on their welfare, property and affairs, and becomes more important as potentially their cognition declines. CGA and integrated care provides a really important opportunity for assessment and intervention with this, and we should really consider financial planning as part of the CGA to empower older patients to be continually independent with their finances and start this when they're well. So since this project, we have further changed our CGA to capture financial planning and inquire about it more. As I said, and we've brought in education for our staff members as well. As I said, the landscape with regards to the Assisted Decision Making Act has just become a little bit more complicated and will continue to be ironed out. I think it was brought in last year, so it is new, and we're all just learning how to interact with it. And just to re-emphasise as well that the Galway Integrated Care members are going to aim to further promote conversations with regards to financial and future care planning going forward. So I'd like to thank especially Maria Costello and Michelle Canavan, who run the Galway Integrated Care Service, for the help with this presentation. Thank you.
Thank you very much, Amy. Room for questions. suggestions, remarks? Maybe you can say who you are. And then
Thank you so much for that. That was so interesting. My name is Serra-Sutton and I'm doing a PhD on 3 in-house outside the country, and they seem to bear on social work. And I'm just wondering, you said there's no medical social worker. Was there any social worker on the team?
Not at the moment.
Okay, but
no.
that's the plan. And then I just had a second question I wanted to tag on as well. Was there resistance? Did you encounter any resistance just about the idea of clinicians taking on responsibility, or not even, but just looking particularly at financial assessment as part of a medical assessment, or did that go smoothly? Because I think it's brilliant that you did that.
So the CGA wouldn't necessarily always be carried out by the doctor. So the GICOP is really a team. Okay. So the advanced nurse practitioners, occupational therapists and doctors, one person would take charge and carry out the assessment, and then the patient will be discussed. So I suppose it's in the context of geriatric medicine, so kind of the holistic care would be our focus. So no, we didn't come across any but as I said, it wouldn't necessarily always be the doctor carrying out the CGA. It would often be another team member. Everyone's kind of, it's equal standing. It's a real collaborative team.
That's great. Thank you.
other remarks?
Hi, I'm Leanne Bruce. From Scotland, part of an allium. It's really interesting that you're using multiple people to complete the geriatric assessment. Does that include reaching out to any formal carers or community supports in relation to the person's situation at home, or is it just within that team?
So the team would be very much so have an integrated approach. So kind of people who are referred to the integrated care service would need usually 2 modes of input. So they might have a medical problem, and they might, so say somebody who's falling would need a medical assessment looking at their medications to see why they're falling, and then also would need a physio assessment. They would very frequently need an OT assessment, and seeing them in their house is very useful because you get a really good idea of how patients are managing. So people who are referred to the integrated care service are seen by either, as I said, an AMP, then discussed as the team with the clinician, and then after that, an intervention plan or a management plan is made, and then at that stage, if kind of community supports will be utilised, and then very frequently, say, formal carers or public health nurses would have been the one referring them in. So it's a real team effort, and then certainly the information from the formal carers in the community is very useful.
Thank you.
Final question?
Thank you for that, Amy. It's a really important project considering how disgraceful it can be for families financially if the person isn't followed up. Well, they're not identifying the people that had dementia or mild cognitive impairment and they didn't have a will or no power of attorney. I wonder in terms of, they've participated and we have the figures, but in terms of follow-up and sort of like duty of care, since these patients were flagged, what happens?
So I suppose certainly in terms of the will, I was very surprised at the low numbers of people that would have a will completed. Promoting it really is the main thing that we're trying to do. So talking to patients and their families about the importance of having a will in place, especially writing the will when you're well, and then ideally getting an EPOA in place. As I said, that can be difficult, and then we're moving more towards having advanced care plans in place. So it's the response to this is really trying to promote it, trying to facilitate people to carry them out as far as possible and provide support moving forward.
Thank you.
Okay, thank you very much, Amy. Then we continue with the next presentation. The next presentation, we fly all the way to Singapore, and Taufik is going to tell us more about their unified needs assessment.
Hi, thanks everyone. So I'm a medical resident in Singapore doing preventive medicine. So I'll be talking to you about our Unified Needs Assessment, a bit about the rationale for why we wanted to develop it, and then a bit on how we developed it and how we plan to implement it. Okay, so I'm going to start with a bit of context. I think a bit of context is important to know why we're doing this project. So I'm part of Yishun Health. Yishun Health is an organization within the National Healthcare Group, which you can see in the center. We really take care of the population within the central part of Singapore. And Yishun Health is really at the very top. We take care of Yishun Zone. We have 320,000 residents that we take care of, and we are an integrated care organization that was formed in 2017 to take care of these residents. And we work with all the stakeholders in the community to take care of our residents. We also manage a 800-bed acute hospital and a 430-bed community hospital where we provide intermediate care for patients. And we also have specialty medical centers. We also help support some of the primary care clinics and so on. So as part of our efforts to integrate care across our whole system, because we have so many facilities, we have so many responsibilities, we thought having a good needs assessment tool was important because we wanted to be able to do good needs assessments both at the individual level and also at the community level for resource allocation and so on. So I'm going to start with what is a needs assessment in my definition. So they are a systematic process for analyzing and describing unmet needs in a defined population. And through discovering these needs, the main goal is that we can allocate appropriate resources and we can design an appropriate care plan for our patients. And needs assessments are done at both the individual and population level, as I mentioned earlier, but we find there are issues with how these are done across Singapore and even in other health systems across the world. So for individual needs assessments, I think the inherent problem is that a lot of them are very much focused on diseases. They are very specialty specific, so you have different specialties having their own assessments. You have different institutions having their own assessments for various reasons, and it's very fragmented. You have multiple different assessments for different reasons. Some of the questions are duplicated and so on, so there's a lack of integration there. And when we talk about population needs assessments, none of these population needs assessments, very rarely do they integrate with the individual assessments themselves. And these population assessments often focus on specific areas. So for example, they'll focus on mental health, there'll be a mental health survey, or it'll be a chronic disease survey for the population and so on. And you have residents receiving multiple surveys for multiple reasons, and there's that lack of integration for population assessments as well. So in Yishun Zone, we really envision a unified process for assessment, and it starts with a single, comprehensive, and person-centered tool that we think should be applicable at the individual level, and that will be applicable to all residents across all care settings. And that is what we envision and what we wanted to develop. And because it's unified, it will enable us to aggregate the data at a population level. And as population health managers, because we also run a health system and we take care of our residents, we can then direct our resources to meet our population's needs. And on top of that, when we have the data, we can then use that data to segment a population and more efficiently decide how to distribute resources and allocate resources to optimize health for our patients, and that improves our individual residents' health. So with this in mind, we had to think about, okay, how are we going to develop a tool that can fulfill these lofty ideals and challenges? So we started with a methodology that began with a literature review. So we wanted to look through the literature to find validated tools that were, as much as possible, person-centered as our starting point. Then we adapted these tools to be more locally contextualized. We also wanted them to be as comprehensive as possible, so they can cover all bases and can really work towards optimizing health and well-being for patients. And at the same time, we also applied systemic design principles. We had to think about how this tool that we developed really fit our use case as a population health manager and as someone who also runs healthcare facilities. And finally, we also had to engage stakeholders. So our stakeholders within our health system, including people who run operations, those that do the clinicians, even those that do clinical informatics. So these were all important stakeholders we had to engage multiple times with regards to implementation and design. So I'm just going to briefly talk about our literature review. So we looked through the literature and we narrowed down a few tools. This is just 4 of them that we narrowed down and we thought were person-centered. But we really focused on the Omaha system. So the Omaha system was actually a framework that was developed in the 1970s, in the US, in Nebraska, and was used in the field of nursing. And the main strength of the Omaha system is that it has a standardized way for documenting and communicating a patient's status or a need status. So that's what we thought was the strength of the system. And it was a really flexible tool. It's very comprehensive. It can be used in all care settings. It has a very standardized taxonomy and needs that I'll show you in the next slide. And it also had the ability to measure knowledge and behavior of a resident. So we thought these were all very useful features in a comprehensive tool. And we also appreciated that other tools also had self-assessment versions. So we thought we could use that quality in our adapted tool as well. So I'm just going to show you what the Omaha tool looks like. So this is the problem classification scheme that the Omaha system uses. It has 4 domains, and it has 42 needs categories, or these are 42 different categories of problems. But we felt the problem in applying the Omaha system as it is to our system, and as population health managers, were these 3. Firstly, it focused a lot on pathogenesis, so there was a very negative framing of health, and we wanted a more positive framing of health. Next, the tool was not locally contextualized, so we felt there were some categories that were missing that we could add in to be more locally focused. And lastly, we felt it was not comprehensive in a few ways. So firstly, it didn't look at children, so there are no needs categories specific to children, like child development and so on. Nothing that focuses, a little bit of focus on preventive health, but we thought there could be more focus on preventive health. And also we thought there could be a better conceptualization of health and well-being beyond just a disease-focused way of looking at health. So we wanted a framework that could really expand and broaden our understanding of health. And we used Maslow's hierarchy. So I think a lot of us have heard of Maslow's hierarchy, but we wanted to use it to broaden and conceptualize what health should be for every resident. So we took these 4 main categories, and we envisioned that biological means or biological needs are the most fundamental for human survival, so they would be at the bottom. And you need to achieve those before you can achieve higher tiers of needs. And that every resident wants to achieve esteem and self-actualization as the final goal. So with this framework in mind, we built on the Omaha system, and we developed a total of 47 categories together with our stakeholders and multiple engagements. And this is what the framework looks like. So we took a lot of the categories from the Omaha, we changed them up, we changed the wording, and we used more neutral terminology because we wanted to align with salutogenesis. We also used terms that were a bit easier to understand from the local context. We also ensured that all the categories were mutually exclusive, so there's no overlaps in them. We wanted to ensure they were as comprehensive as possible or totally exhaustive of all the needs that a resident would have in our population, and be able to achieve self-esteem and actualization. That's why you see categories like confidence, improving myself, and these were not categories in the Omaha system. And importantly, we also wanted to think about children, so we added in development at the bottom left, and we also added in a few categories related to prevention. So you can see screening and vaccination in there as well. And we also, this is how we developed the problem classification scheme for our tool. But we needed to think about now how we're going to actually collect data from our residents. And so we started to think about that process and that path we were going to use. And together with our stakeholders, we narrowed down to 5 steps that we would have in this process. So the first step was to identify signs and symptoms or challenges. So it sounds very disease-focused, but this is how the Omaha system calls these questions within each problem category. So even within social care needs categories like things like confidence or things like mental health, there are signs and symptoms, but they are not disease-focused questions. So just to clarify that. And challenges were how these questions were phrased if you were to do this as a self-assessment. And this self-assessment version was adapted from another program that was developed in the US called My Strengths, My Health. So it's also a validated tool that we adapted for the self-assessment. And the goal of this first step was to identify actual or potential needs in our residents. In step 2, we also wanted to grade how severe the needs were in the patients, and we can use that to kind of prioritize our care plans for the residents. In step 3, we also wanted to do a behavior and knowledge rating, and the idea was that we could guide residents to close their own gaps in their own ways by improving their knowledge and by engaging in behavior change. Step 4 was the asset discovery tool, and the idea was that if we could document resident assets, we can then incorporate them into the care plan, and this is the basis for having a strength-based framework, and being able to use the patient's own assets to improve their care. And step 5, we wanted to also capture anticipatory concerns. So beyond just actual and potential needs, we wanted residents to think about any anticipatory concerns they could have. For example, middle-aged woman who's thinking about pregnancy, she may have concerns, she may have questions to ask. So we wanted to capture all that and be as comprehensive as possible in the process. So in discussion with stakeholders, we put these 5 steps together in this order. The idea was that it will help practitioners differentiate the types of needs. So you can see we differentiate between unmet needs and needs that are considered met. And we can also, through this process, identify anticipatory concerns and needs. And if there are unmet needs, we do grade the severity of the need. And the idea, again, is for care plan prioritization. And at the same time, we assess the behavior and knowledge of the resident, so we know how to improve on their care. And these steps will be carried out for every one of those 47 categories. So it seems like a very big task for the individual to do an individual assessment. But maybe in the next few slides, I'll clarify how we wanted to make it into a very efficient process. So as I mentioned, now that we had the tool, we need to think about implementation and how we can make it efficient to be completed. So I think the most important prerequisite and criteria in order to get this implemented was that we needed someone accountable, a single individual who could be accountable for the data that they're going to collect, accountable for ensuring that the resident has an assessment. And we decided that this would be a physician, and we termed this person the primary coordinating doctor. This primary coordinating doctor would not be able to complete the entire assessment for every individual. It'll be too much work to do. So the idea is that we could get the assessment completed by multiple different stakeholders within the health system. So you can have your social workers, your community health teams, your primary care doctors, or even specialists contribute to different parts of the assessments depending on what is relevant to them in their care. And all of this information goes to the primary care doctor. But at the same time, we also mentioned we wanted to have self-assessments. So on the other side, we'll get residents to do their own assessments. The caregivers could do it for the residents if the residents could do it themselves. Or we could even have community workers or community health teams do it for the residents. And we envision that these self-assessments would make up the bulk of the information for the otherwise very healthy residents in our population. So the role of the primary coordinating doctor is really to bring all this information together, deconflict contradictory information, and also the final the information that they approve as the final assessment is the official representation of the patient. And this will be facilitated by a transactional system, which is the National Electronic Health Record that we have in Singapore, which is EPIC. And the idea is that this system will allow for data transfer seamlessly and at the same time ensure data security. So the primary coordinating doctor's role is really to ensure the needs assessment for an individual is collected accurately and that they're responsible for the data that's collected for the individual. But this data would be stored on this electronic system, and any provider could access this information. So you could be a physiotherapist who's seeing the patient, and you want to know what the patient's need status is, so you can address these needs accordingly. And at the same time, as population health managers and people who run a health system, we also want to be able to take this data, and since it's unified, we can aggregate this data and we can use this data to decide on how we're going to allocate resources to our population, also how we're going to develop segmentation models to decide how to efficiently allocate resources to them as well, different segments of the population. So last slide. In conclusion, we think a comprehensive and person-centered needs assessment is the future for value-based health systems like ourselves in Yishun Health. And we think having a unified and standardized tool for needs assessments really enables the work of population health managers, and at the same time will also support our doctors and clinicians and healthcare workers on the ground. So this unification of assessments for individuals and populations will help us achieve integrated and effective patient care and also effective population health management. So some of the features we think are very interesting for our tool that we've developed so far is that we want to have both provider assessments and self-assessments contribute to this needs assessment for the patient, because we think the self-assessment from the patient also provides their perspective and their inputs on their unmet needs. And at the same time, also having a national electronic health record, which we are working towards in Singapore, is very helpful for making this a reality. But of course, we still need to do a bit more work to ensure it can collect the needs data that we want it to collect. Some future work that we still need to work on is, of course, I think getting healthcare workers on board is very challenging. I've had to engage with lots of different healthcare workers that were pushing back. And I think getting them on board, one way to do that is to find a way to map all their existing scoring tools into our needs assessment. And at the same time, the other thing we are thinking about is how we could use this needs assessment as a way to enable healthcare financing through capitation. So that's things we're thinking about for the future. So I will stop here, and we can, for Q&A, and if you need to connect with me, you'd like to connect with me, you can scan the QR code. Okay, thanks.
Thank you very much, Dr. For this nice presentation. You have a question. You can't wait. 1, 2. Okay, maybe you can.
Thank you so much. I'm Pauline Pariser. I'm with the University Health Network in Toronto, Canada. I have 2 questions. The first one is, what is the time frame that people have to collect this information? And is there consideration of administering the needs assessment more than once? Like at what, how do you figure out the age categories? I just was interested in that. And the second question is, how do you design the tool so that it meets the needs of people who are structurally marginalized, who have poor educational levels?
Okay, so for the first question, so I guess this is one piece of a very big puzzle in our health system. We have so many ongoing projects, and right now we're thinking about doing it at a yearly interval, so annual assessments. But of course, I think this is still in flux. We're still discussing with our stakeholders whether this is reasonable, whether it's possible to do it, and whether if we don't even have a completed assessment at the end of the year, what's going to look like the subsequent year. So right now we're thinking annual, but this may change in the future. And your second question was about marginalized populations. So I think what you pointed out was also along those lines was that we haven't really engaged people on the ground, haven't engaged our residents, and that's another step we need to take moving forward. Currently, this is really still in the early stages of development. So these are some of these ideas are something we're thinking about moving forward, because we're going to have to keep improving on this tool. And the fact that we're doing self-assessments means we probably need validation from the residents on the ground for them to understand the questions that we're asking them. So that's definitely a step we've got to take. And I think speaking to the marginalized populations is very important. In Singapore, we have a lot of minority groups, including the racial groups and religious groups. So that's also a very important consideration for us. Yeah.
Thank you so much.
Hi, thank you for your presentation. My name is Anne van den Bulk from Maastricht University, the Netherlands. I'm an assistant professor over there. And I was wondering, as I have experience with collecting data for patient classification in a case mix system, we explicitly didn't use OMAHA system as we had some trouble with the standardization of the data. And that might be because it's totally different in the Netherlands, as we do not have one system overall. Home care providers, healthcare providers, actually nowhere. But I was wondering, did you consider how you would dig a bit more into the standardization of those different aspects of the OMAHA system? As I can imagine that with all those different kinds of professionals, that might be quite a challenge.
Yep, so I guess when we were engaging some of the healthcare professionals, some of them saw it as, okay, this needs assessment is going to remove all my other assessments, but we don't want it to be that way. The healthcare professionals should still be able to do their own specialized assessments or specialized history taking. This is not to replace the history taking or physical examination in any way, but this is to provide the health system and the primary coordinating doctor a comprehensive understanding of the patient. With regards to why we chose OMAHA, we just thought it was the best tool that we could use as a starting point. I think compared to the other tools out there, we still felt it was quite comprehensive. But that's why we still did the adaptation after that. And we still use Marcus Lowe's as a framework to do the adaptation, because we thought we could still build on that comprehensiveness. And that's why we integrated all these locally contextualized categories in there as well. Yeah, I hope that answers.
Thank you.
Okay, thank you very much. We continue to our next presentation. We go back to Europe again, so we go to Finland. And we go to Timo Sinervo, and Timo is going to tell us something about the assessment of service integration in Finland, but he's going to use the Scirocco tool. Timo, the floor is yours.
Okay, thank you. It's here. Yes, I'm coming from Finnish Institute for Health and Welfare, which is THL, and we have tried to assess our integration using this Scirocco tool. And we are not trying to invent it again. We are just trying to find out is it suitable or not to analyze our system. And background to this is that we had very large system reform in our health and social services. We might say we are fully integrated, at least at organizational and budget level. We have 22 plus 1 county which have responsibility for arranging all health and social services and rescue services. And the money is in these counties also. So we are not having any different sources for this, where this money is coming. Except that we are having occupational healthcare system, which is totally separate system for employed people, which is one of our main problems now. Anyway, we had 150 municipalities who had responsibility earlier, now 22 plus 1. It started at 2023, but actually 9 regions started this earlier in voluntary basis. Also, these counties are providing the services by themselves mostly, but there are some areas they can outsource services also to some extent, not all services, because we need the counties to have also their own services. For example, assisted living services for older people, mental health, majority of these services are outsourced nowadays. Some also on primary care. We have actually very long tradition on having integration. Our health centers have always been from 70s multi-professional organizations, which is our primary care. But still we have also several problems at the floor level. Organizational integration doesn't mean that everything goes smoothly at the patient and doctor nurse collaboration. And in practice, integration at the floor level, it varies very heavily in between counties and in municipalities also. And now, as with integration was one of the driver of our organizational change, we would need to also measure it. But there is a problem that there is a lack of measurement instruments, because most of these instruments are disease-specific, and these kind of overall measures are very rare. So this is our group. We had researchers from THL and also University of Turku, and also Center for Client and Patient Safety. I'm not going to talk much about these dimensions, but we just like these dimensions because it's not one thing only, it's several dimensions that have to be realized if a real care integration can happen. So we translated this Scirocco tool and also modified it to our Finnish health and social system, which was actually not so easy because our system is quite different. For example, because our social services are also in the same organization. And we had 4 well-being service counties and tried to gather information from them, suitability of this instrument in county level, in development, and also comparison between counties. And as this tool is mostly used as a development instrument, for example, top management team is sitting and discussing of care integration, they can use this tool. But we used it as a survey tool, and it's a bit exceptional looking survey tool. So we tried to find out, is it working really? We also made a review of our measurement tools, but were not many comprehensive tools actually. Data is quite small for quantitative study. We only had top management, middle management, frontline managers, and some frontline workers too. We had only 135 answers because this was kind of a pilot study. Yeah. Now, something about these results is that there is quite strong differences between professional groups, with darkest area, which is going to number 4, and number 3 is top management, and the inner circle, that's frontline workers who think much more negatively on what's the status of a maturity of a care integration in their county. So top management thinks much more positively about these things, and it may be quite natural because care integration is at their work table. They are doing it and planning it, and they think the plans are now ready, but actually the implementation is just starting. Here, 1 means that nothing has happened, 0 means that nothing has happened, 1 means that some plans and something has been recognized, but something has to be done, and number 5 would be full maturity of integration. Largest differences are in readiness to change, organizational structure, and in some counties this organizational structure there was huge differences between top management and frontline workers. Also digital infrastructure, because these counties have formed from 10 to 20 municipalities which all had their own patient records, meaning that the counties are just planning to get their own unified patient and record for health and social services. About counties, with numbers B and C, they are those counties which were formed earlier than the other ones in voluntary basis, so they had also some years to develop their integration beforehand. And they are with, is there a point or not? Yeah. With two are these counties which have started earlier. And we think this is quite a positive thing for this measurement also, that there is variation, and this variation is logical. Because in these other counties, they have been just formed in beginning of 2023. So they had only started their planning of everything. Okay, what about suitability? We also collected some information from counties and from all these questions. And the counties thought that it was a suitable tool, and it gave suitable and useful information for them. For example, top management recognized it very clearly that we have different views from frontline managers and frontline workers. And they thought that follow-up is needed, and actually at least 2 of these counties are continuing with in the spring. And we were happy that there were differences between counties that might have some kind of implication, but this tool is a reliable measure. There were actually also some difficult parts. For example, evaluation and funding. It was quite difficult to answer for the frontline workers because they didn't really know about evaluation and funding. Is it good or bad? They knew that their salary doesn't change even if they do anything, but other things they didn't know. So we found out that we need some kind of further development, at least if we are using this as a survey instrument. Because in this instrument, one question actually had several questions inside. And this is quite okay if you are using it as a developmental tool. But for a survey instrument, it's difficult to answer at the same time for 3 questions. So now we are trying to separate these questions to 3, maybe 4 different questions. In the left-hand side, you can see what was the question originally, and you can see it's quite long expression of what does, for example, readiness to change mean and what can be evaluated. And as I said, it's pretty good tool for if you are sitting in this table and thinking about your organization, you have these questions to help you think what is readiness to change. But for the survey tool, we are now trying to convert it to different questions, meaning that this readiness to change would have, for example, 3 different questions. And don't read the wordings, it's just scratched by hand. Now it's not the final version. This is what we are trying to do now, and let's see what are the results. And here's something we have been doing in Finland. There's something about Finnish system and also with original Sirocco references. Thank you.
Thank you. Questions, thoughts, reactions, ideas, how we can develop?
Thank you very much for your presentation. The Sirocco tool is quite dear to our heart in Scotland because we were heavily involved in some of the early piloting. I'm just wondering if some of your results might have looked different if you had citizens or more public partners responding to your survey rather than just managers and professionals.
About who was answering to this, it was only the public side, because this was kind of a pilot. And in next phase, we might also take some private service providers, because of course we know that there may be a gap between the public services and private services, because we have a different kind of compensation for the services and integration. I would say, but mostly it's not taken into account in this compensation system. And yes, I was a bit afraid, what are you asking about Sirocco, as I saw you in the speaker list. Yeah.
Thank you, Timo. Others? I have a small question. You touched upon the different perspectives on integration by showing the maturity index for different groups. Do you think it's feasible to have one instrument that is applicable for all the different groups, like frontline workers, higher management,
No.
maybe even patients? And is it feasible, or should we forget that?
Yeah, you are quite right. But let's take, for example, our health centers, which may be 10 health centers in one county. In one health center, which may be at very good level. But it's also possible that we are not only asking from top managers and middle managers, but We are taking some areas, for example, health centers as a topic, or diabetes or something else. So this is just beginning.
Under discussion. Thank you very much for your presentation, for your contribution. We head to the other side of the ocean. We go to Canada, and for people who came from Matthew Myers, that's a disappointment, but we are very lucky that Jacoby Elliott is here. Matthew had to be in 2 places at the same time, which is not possible, still not possible. But you are going to tell us about your experiences about a holistic needs tool.
Yes, great, thank you. So I'm Jacoby Elliott from Ontario, Canada, and I'll be presenting some preliminary work on developing a holistic needs screener. I'm presenting on behalf of a large group of people, and my colleague, Dr. Sarah Jarmain, is here as well. So before we describe the development process, we wanted to start by grounding this work in population health management and the framework here on the screen. To do population health management well, you really need to understand your entire population and segment the population based on risk and need. Unfortunately, we don't have a really good process in Ontario to understand our full attributed population. So this has been really the reason behind this work. How can we build a tool to help us understand the full population that we should be caring for in our community? So we set out to develop a short screening tool that would help us identify those who need services in our region. We wanted a really short tool with high-level questions spanning different domains of health and wellness. We wanted the tool to be self-reported to enable people to self-identify their needs. And we wanted a tool that led to next steps, such as suggestions or referrals to other community services as appropriate. Through interviews and co-design sessions with patients, caregivers, and providers, we heard that people wanted a quick tool that could support identification of a need and also promote early diagnosis. We also heard the need for more information and education about available resources in the community. So again, really wanted a tool that had questions that identified the need and then defined actions based on the results from the tool. Additionally, in Ontario and in Canada, we have a large population of patients who don't have access to primary care. So we wanted a tool that could help us assess for health changes in our community, especially for those individuals who are unattached to a primary care physician. So overall, we had about 80 providers, patients, and caregivers contributing to the early development of the tool and the associated care pathways. Through co-design, we landed on a definition of health and have based the screening tool on domains off of this definition by the National Collaborating Center for Determinants of Health. So they define whole health as the physical, spiritual, mental, emotional, environmental, social, cultural, and economic wellness of the individual, family, and community. And there was a lot of work that went into this with our co-design sessions and a lot of debate around the different domains and what each domain means, and a lot of complexity around the difference between emotional and mental. So it took a lot of time to sort through the definitions of the domains. We also did a little bit of a literature review on existing tools, and we didn't find one single tool that really matched these 8 domains. So that really led us to thinking about developing our own tool and what that looked like. We definitely didn't want to duplicate what was out there, but we just didn't have any luck finding a really short screening tool that matched what we were looking for. So as we started building the screening tool, we developed a number of functional requirements in partnership with patients, caregivers, and providers. So again, the tool needed to trigger actions and care pathways based on the screening results. The tool should be able to monitor health and health changes. It needed to be quick and easy to administer with fewer than 10 questions. And we wanted it to be inclusive of those domains that we landed on. We wanted it to complement more in-depth assessment and not duplicate the existing tools that already exist in our healthcare system. So we ended up developing a partnership with IJIC, a collaborative network of researchers, clinicians in over 35 different countries around the world. So IJIC has developed a number of healthcare instruments designed to be used across the healthcare system. but currently many of those tools are more detailed assessments. So InterRI was really interested in partnering with us to develop this holistic needs screener that would identify appropriate individuals who would then go on to complete more in-depth InterRI assessments. And we believe this tool will be applicable to communities outside of Ontario, and leveraging the InterRI network, we can test this tool in other countries as well. So InterRI tools are validated and reliable tools, and they have a whole bank of questions already validated. So we were able to align InterRI questions to the 8 domains that we were interested in. So this is just an example here on the screen of some of the questions that we could have selected for this physical health domain. So how would you rate your physical health? Do you get help with basic activities? Or in the last 3 days, how often have you had pain? So while we're in the development testing phase of our screener, we're having a few different questions for each domain, but our hope is that we'll narrow it down to just 1 or 2 questions per 8 domain. So we wanted to highlight a little bit of a case example of how we envision the tool in practice. So let's take George, a 62-year-old male who recently moved to London, Ontario, Canada. He is generally healthy, and he completes the screener. Maybe it was emailed to him. He's new to the community, so he does not have access to primary care right now. He identifies he's lonely and feels down. So what do we need to do about this? Through the information gathered in this screening tool, he can then be contacted by a community partner who can provide him with options for self-management and education. At this point, no further actions are taken, but we can check back in 6 to 8 weeks and see how he's doing with those self-management and education suggestions. We can take this same example, but let's say George actually has a number of health concerns and identifies that he struggles to get out of his apartment. So in this scenario, with our screening tool, we would actually, and based on his results, we would actually connect him to a community navigator who could provide, rather than providing the education and self-management options, he would get a full comprehensive assessment and would also be referred to appropriate services. So he'd be connected to services for support for his healthcare needs. So these are just 2 examples of how the tool could be utilized based on the individual's needs. And of course, since we know he's new to the community and isn't currently connected to primary care, we would get him on our large roster to be connected to primary care. So again, we envision the resulting tool will triage individuals based on level of risk and connect them to the most appropriate services, depending on how they answer the questions. So those at low risk would have more of the self-management education options, and those at high risk would be referred for more comprehensive assessment and likely using those more in-depth InterRI comprehensive assessment tools that are already in place in our system. So again, the beautiful thing about leveraging InterRI is it's already a common assessment used across many of our healthcare sectors. We just really wanted to build that screening aspect. So currently we have identified the InterRI questions based on the domains, and we're now in the process of testing this tool and the associated care pathways that we've co-developed with patients, caregivers, and providers. We'll test the tool with a sample size of about 300 individuals to check on our algorithm and see how the pathways worked out before rolling this out to our full attributed population. We will continue to engage our patients, caregivers, and providers in this work as we learn about the tool and how it performs in practice. So we look forward to sharing the results at next conference, IFIC conference. And I'll leave it there and invite Sarah to come up and help answer some questions.
Thank you, Jacoby. Very interesting. Yep, I already see one question.
Thank you. Very interesting plan and presentation. Monica Perez-Yales from University of Colorado, United States. We are trying to do something very similar. My question is, how do you envision including the 8 domains, very interesting, whole person care, with a fast tool with just 10 questions? We struggle with that, the usability and pragmatic tool versus the 8 domains are amazing. How are you handling that, planning?
Yeah, I can start. It's a great question, and I think something we struggled with when we did the literature review to look at existing tools. We just couldn't find something that touched on the 8 domains. And again, I think that's why InterRAI was really interested in this partnership, because although they have a couple of screening tools, their screening tools are very specific to a specific condition or category, so a mental health screening tool, for example. So that's our challenge right now. Our tool sits at about 16 questions. Because we do have a few questions per domain, but through our testing phase, we'll see which which question is performing better to trigger need, and see if we can get it down to hopefully 10, but not sure if you have another answer.
Maybe just to add, I think we had a lot of discussion about the difference between screening and assessment. And so screening is really to identify from a patient's perspective, or sometimes family caregiver's perspective, is there an issue, concern, or a need that then we have to ask more questions about. And so it's really having that opportunity. You know, many people will say, you know, most of things I'm great, but I just got notice that my apartment building is being sold, and I'm really concerned about what's going to happen if I don't have a place I can afford, right? So it's separating those two out. It's also thinking about where along a patient journey are the appropriate places to use a holistic needs screen versus where are those places that right from off the start we're going to want to do more of an in-depth assessment.
Others? Oh, that's in the back. No, you need the mic because they can't hear you.
Maxine Radcliffe, work in various things in Ireland, in the Republic. Curious to know if you are interested in other partners collaborating to operationalise something like this in terms of the research, because what you're describing is the kind of thing I need to stand up yesterday in migrant and homeless services, and I'd love to collaborate with you on it.
Yes, absolutely. And again, I think that's the beautiful thing about the network that InterRAI has is we can connect with many countries around the world and collaborate. So let's connect after.
Others? Yep.
Can I ask you, is there a plan to link the high-risk people with prioritising them to have a GP? Right? It sounds concerning that there would be a 62-year-old with diabetes with no primary health care doctor, or might that be an integrative?
So sorry, let me make sure, because it's hard to hear. So your question was for the high-risk individuals. What are we going to do because they don't have a primary care provider, and what's the pathway for them? If I got it? Okay. So lots of conversations happening right now. We're just in our evolution implementing primary care networks, and this is one of the major areas of accountability that's envisioned for primary care networks. So we're having discussions around different models for unattached patients. Some communities have set up pop-up health clinics. Others are really working to say, how do we pull together teams that may work in different ways to be able to create some capacity to manage that. One of the examples in our community right now is the Health and Homelessness Whole of Community initiative, and as part of that there's been some government funding to specifically target some of those highest need individuals, and it's really a network of different organizations coming together to say, how do we meet this need in a different way?
I think I'll just add, just based on your presentation, and I have an interest in geriatrics as well, I think, you know, we know that for older adults need to be referred for more comprehensive geriatric assessment, and those without primary care are not getting that referral because no one's signing off on that referral. So having mechanisms like this tool and then someone who can take accountability to make that referral, and then they can get to the right place to get the assessment they need at the right time.
Other questions? Final one, yes?
Thank you. So my question is, what is the eligibility of people who will participate in the screening. So it's everyone they will they will do the screening voluntary, or you have some target population. Thank you.
Yeah, great question. So I should have mentioned that the tool is for those 18 years of age and older. And in our testing phase, targeting a few community partners that can help us with a variety of people in our community. So though newcomers is a large population in our community, those experiencing homelessness, and then we're also partnering with a primary care physician who has a vast population that he serves in his roster. So for our testing phase, really looking at across diversity of the community.
Yep, and I think once we're through that and have implemented the tool, the idea is that everyone in our attributed population, which is a combination of geography plus who is rostered to particular primary care providers, would have the tool. And as new people come in and they're interacting with the system, if they haven't had it yet, that would be the opportunity to do that. But that's where it ties into that attributed population registry to be able to hold that information.
Thank you very much. So a nice example of a screening tool instead of an assessment tool. So I think we need both of them. And we fly back then from Canada to Scotland. We're going to Anne Henry, and she's going to tell us a little bit more about the understanding the value of a compassionate community. Anne, floor is yours.
Thanks very much, Mark. And I was reflecting all of the other wonderful presentations have all been about assessment and analysis, so I'm going to fast track you to the review part of that commissioning cycle. And I'm going to talk about work that's really been led by Alison Bunce, who can't join us today, but hopefully she'll be watching live on stream. And it's been led by Compassionate Inverclyde, which has shared its story a bit at the IFIC conferences before. It was established in 2017 as the first compassionate community in Scotland. Last year we heard about the wonderful Caring Neighbourhoods development in Flanders, and I think yesterday they were having their evaluation conference. A community where everyone recognises we all have a role to play in supporting each other at times of crisis, end of life or loss. And it's about ordinary people helping ordinary people. Its purpose and its values of kindness, helpfulness, neighbourliness were co-designed, co-developed through conversations. So very much reflecting what we talked about this morning in the plenary, about having those good conversations with local people, local citizens about what matters. It's very much aligned with Scotland's national values, although it's a community of about 80,000 citizens. It's aligned with the country level values. We are a society that treats all our people with kindness, dignity and compassion. That's the values we aspire to, respecting the rule of law and operating in an open and transparent way. It's a collaboration. It's not a single organisation. Compassionate Inverclyde had multiple partners. And again, I think what we heard this morning from New Local and from colleagues in Northern Ireland about creating productive partnerships where partnerships of equals. So although the local government and the health and social care partnership and academic organisations were around the table, so too were the police, the hospice, and other third sector organisations like Macmillan, the Health and Social Care Alliance colleagues, and Your Voice, a local mental health advocacy organisation. So it really was a team of partners. But the most important people were not the organisations that were around the table, but the volunteers who were out there doing the doing. It really was, and is, a social movement of of local citizens, local people who respond to call-outs or shout-outs through social media, through the print and radio media, and give the gift of their time, energy, creativity, and compassion to support their others in their community. A whole range of initiatives that since its inception have developed over the time. A little bit of pivoting during the pandemic. Obviously, some of the face-to-face activities had to shift to more physically distanced support. But despite that, and if perhaps not despite it, but perhaps because of it, has thrived and flourished and grown to the extent that it was decided that actually it's more than a social movement now, and now is a registered charity. To a certain extent, the evaluation has been iterative over the period of time. In the early stages, probably only about a year to 18 months in, my team with IFIC Scotland and some academic researchers did what was largely a qualitative report, reflecting on the individual, the relational, and the community outcomes that were achieved. Vast range of outcomes, from increased confidence, self-esteem, a sense of belonging, to that reciprocity between people who are receiving kindness and those who are giving it, to the community well-being, where there was a real sense of building that social capital in community, a community with a greater sense of hope. So all of that evaluation material is available, and was really pretty powerful in terms of all of those partners around the table. But to a certain extent, as we were beginning to move from a social movement where we had collaboration with some of the statutory organisations and potential funding partners around the table to being our own charity and being let go, we thought we'd probably need more granular evidence around the difference it's making. Yes, we know all about the well-being, the reduction in isolation, the sense of belonging, and the opportunity for people to visibly show their caring and nurturing selves. But could we quantify that? Could we be a wee bit harder? Because when it comes to putting in grant applications, those of you in the room who are working in the third sector, I am as well, working with my local hospice, we have to be quite hard-edged. I was very inspired by the comments this morning in the plenary about trusting the process and not necessarily needing a full business case to be, but there's very few funding organisations or commissioning organisations that are in that ethical commissioning space. So how could we quantify some of that value and show that it was truly reducing service demands and costs? And I have to say here, full declaration, I'm not a health economist, and none of my team were, and we didn't have the time or the budget to be able to do a really whizzy, glamorous economic evaluation, and I'm really waiting with bated breath to hear what comes out of the Flanders work so that we can stand on the shoulders of giants. But we were actually surprised by how relatively easy it was to find costs avoided. Once we started looking at the No One Dies Alone companions in hospital and at home, that was releasing a healthcare worker or a social care worker who was not required to sit with the patient and family. So once we started adding up those hours of volunteer support that released staff time, and we costed that, big costs avoided. Similarly with other initiatives, perhaps less costly staff time being released, but it all mounts up. Every penny counts. What surprised us again was that, we knew that the back home boxes, the boxes that people returning home alone from hospital got, regardless of age, with small essential food and items to help tide them over the first few days at home that can be quite rocky, as we all know, having been discharged ourselves or received family who've been discharged. We all knew that there were some benefits from these, but actually what really surprised us was the conversations with hospital staff who said, we're really confident in sending people home alone now because we know that they're going home with food and things to make a meal. We know that they get a get well card written by a local school child. They don't feel alone. And a subtle shift in the culture and practice within the hospital team. And you can see how well received that little box of love is by patients who are going home on their own, feeling quite vulnerable, but know that there is help there if they need it, and they could ask for a back home visitor if they feel that they are not immediately confident. And it's interesting that the orange line is the performance of delays in discharge home from hospital for the area compared to the national average, and the lower the better. And you can see Inverclyde was already a good performer, but there's certainly a sense that trend is slightly widening, but certainly we think that the delayed discharge performance is helped by having the back home boxes, so much so that the chair of the health board, the partnership is only one of a number of municipalities in that big metropolitan health board area, said he wants this rolled out in all of his local areas. We tested some assumptions, and you could say actually maybe these are still too ambitious, but we tested a range of assumptions with our chief operating officer for the hospital, with the discharge team, with the social care, home care provider, manager, and we came to an agreement where, okay, if we said even 20% of those returning home alone go that day and not the next morning because they're going home supported with the box and with what comes behind the box, that's big savings. And similarly, if we said that even there was a 50% reduction in the number of people who are getting a 30-minute just checking visit on the day of discharge or within 24 hours of discharge, then again, that's a saving. There were lots of other strands of work. The High Five Wellbeing Programme was particularly focused on children, primary school age children, as well as adults who are probably some of the most marginalised members of the community, staff in prisons, prisoners, people working with homelessness. We actually never quantified that. Because we just didn't have the time to go through all that, nor did we look at some of the individual and organisations' kindness awards. That was another strand of work. So people could nominate somebody in the local community who had really stood out to them and helped them at a difficult time. So here we see Charlotte, hairdresser, who really helped somebody cope with cancer because of the way she approached the hair loss and all of the self-esteem that goes with that. We didn't also look at the bereavement training that people had gone through as part of the organisation Inverclyde's support and journey towards bereavement charter mark status. But we certainly, I think, over all of these other strands of work, were able to identify a huge amount of social value that had been created, very similar to the early evaluation from 2018. But we were able to quantify some of that social value. We looked at the Housing Association's Charitable Trust Social Value Bank, which is a great source of being able to put meaningful, quantifiable value against certain outcomes. It's a great resource. And we chose two outcomes that were commonly experienced by people receiving some of the initiatives. We looked at that feel belonging to a neighbourhood for the people who were attending the Friendship Hub. 45 individuals. The 1 year value was estimated to be just short of £4,000. That was contrasted with the other outcome that had a value, which was relief from depression and anxiety. So while the first one was probably more of a sort of chronic state, feelings of excluded and not belonging, so the intervention helped to address that over a longer period, we felt that we would only see maybe a short-term response or result from the intervention around back home visiting or palliative care companions or new mums companions, because we thought probably there was only a sort of transitional sense of well-being that was affected and then, you know, supported. So we gave that a higher dead weight, a higher attrition, and we only said that there was about a 20% attribution to the intervention. There were other interventions that were at play for that particular group. So we took sort of two extremes of social value and we calculated that up. Once we did all the maths, we were able to say that, you know, staff costs avoided and tangible benefits were estimated at over 800,000, and the more intangible benefits just from those two outcomes for a small subset of the interventions by the social movement was again almost £500,000. Total estimated social value, easily, conservative estimate, over £1 million, for annual running costs of about £82,000. So over the 5-year period, bearing in mind that, you know, there'd been a lockdown in the middle of this, at least a 3-to-1 return on investment there. Now, as I said, I'm no economist, but this was good enough to really help the commissioning team, the Health and Social Care Partnership, who wanted to invest in this, but needed to have some evidence. And so for me, it's been a learning journey going through this piece of work. I think quantifying the value of an initiative like this is feasible. We learned that we shouldn't be too ambitious. It wasn't possible to measure everything. So we focused on some things. We started somewhere. We were quite clear about who we were trying to influence, you know, particularly the Health and Social Care Partnership who were commissioning. So we focused on the things that we thought mattered to them, like the discharge from hospital. We have popped up the literature, the reference sites that we found very, very helpful at the Social Value Bank. And we learned that we had to have really honest conversations, that we weren't going to over-attribute effect to the one thing, because we all know complexity contribution analysis is what's really important. So we didn't over-attribute, and we felt that these of good enough calculations might actually be enough to convince funders. And actually, since we did this piece of work, we've landed a big lottery fund for 2 years, which is amazing, and also a health and well-being award. So just wanted to share that very pragmatic approach with you. I hope there's no health economists in the audience, but be kind to us. But you know, it's be ambitious, be courageous, and you know, don't ever apologise for doing something that looks a bit soft and woolly, because when you get your head round it, actually, this is really delivering value. Thank you.
Thank you very much, Anne. A very compassionate story as well. Questions, remarks, suggestions? Yes, please.
Thank you so much. I always love the presentations from Scotland. I'm Pauline Pariser from Canada. The compassionate communities remind me of another term, resilient communities, and particularly with the predictions of climatic crises, further pandemics, and the impact on the vulnerable. I didn't see this, and it may be something you're considering, initiatives that would be proactive around, inclement changes in air quality, in excessive heat. So I don't know if that's being incorporated or considered, but ways in which people who are vulnerable could be connected to resources early in those processes.
Yeah. No, what a great question. And I guess partly the absence of that is partly because some of the real challenges in that particular geographical patch are probably more around poverty and social exclusion and stigma. But you're absolutely right. When you look at some of the other areas of sort of caring neighbourhoods, caring compassionate communities around the globe, looking at climate challenges, as whether it be drought or fire, looking at what you've experienced in Canada, what our colleagues are generally experience in Australia, they're huge. That particular community, climate is not their biggest issue, but it's a great connection and an opportunity for me to advertise tomorrow lunchtime. We have a small islands special interest group which is evolving to a remote, rural and islands special interest group. So come along tomorrow, look at it in the web pages if you're interested in that stuff, because that's what we want to get into. And we have, as part of that, we have the Seychelles. Last month I was talking with the WHO Afro Small Island Developing States Community of Practice, and that's the stuff that they're really worried about.
Well, next to that advertisement, is there another question? I have one last one for you. If you look at the other presentations that were about screening and assessing, and then I saw your whole list of very nice initiatives of all the volunteer organizations that took place. Is there a connection? Do you see a connection?
Yeah, absolutely. And one of the beauties of the arrangement that we've had is that the citizen-led social movement, the volunteering, is done in partnership with the Health and Social Care Partnership. And the Health and Social Care Partnership was very well led. The chief officer, who's now the chief executive of the local council, had a very mature approach to partnership, very similar to what we heard in the plenary this morning. Felt as if this was a partnership of equals. It wasn't the big organisation commissioning to small provider. It was genuinely understanding the value of third sector partners and genuinely understanding the power of local people to do amazing things.
Okay, thank you very much. This was Anne. This ends the session. So I hope you enjoyed it. We had a good conversation from all around the world, and I think now it's lunchtime, and people